My name is Hamza Akram. I'm one of the internal medicine interns at AdventHealth Orlando, Florida. Today I will be sharing a case of Cutibacterium ventriculitis in a 74-year-old male with known history of non-pressure hydrocephalus. NPH presents with a constellation of symptoms including gait disturbance, cognitive decline, and urinary incontinence. Ventriculoperitoneal shunts improve symptoms but carry a risk of infection. Herein, we present a case of Cutibacterium acnes ventriculitis in an NPH patient, highlighting the diagnostic and therapeutic challenges we faced to encounter this organism. So, this is a case of 74-year-old male with a known history of NPH, for which he initially underwent VP shunt placement in 2016 and then a revised shunt was done in 2020 due to mechanical malfunction. He was doing well until a year ago when he started having progressive memory impairment, gait disturbances, and new onset urinary incontinence with unexplained low-grade fevers and worsening fatigue. On examination, he was alert with mildly disoriented to time, had a broad-based shuffling gait, and mild lower extremity weakness. However, vitals were stable on admission except for mildly elevated temperature. We could not appreciate any focal neurological deficits aside from gait changes. The shunt site appeared intact without erythema, tenderness, or any signs of infection. Lab work revealed a normal white count, elevated inflammatory markers including CRP and ESR. Imaging, including CT head and later an MRI brain, demonstrated unchanged position of VP shunt. However, it demonstrated enlarged ventricular size when compared to prior studies, without any evidence of acute hemorrhage or mass lesion. We obtained CSF via shunt tap, which showed elevated white count with a normal protein and low glucose, raising suspicion for a bacterial invasion. Gram stain was negative. CSF culture initially showed no growth at 48 hours. However, after 5 days of incubation, C. acnes was isolated. Antimicrobial susceptibility testing demonstrated susceptibility to penicillin, ceftriaxone, and vancomycin. This case was discussed with neurosurgery and infectious disease, and it was decided to remove the shunt system in its entirety and place an external ventricular drain for drainage with the delayed placement of a new shunt system. This patient was initially treated with IV penicillin followed by IV ampicillin followed by IV penicillin G for 14 days and then further treated with ceftriaxone for an additional 4 weeks. After we obtained follow-up sterile CSF cultures, a new VP shunt was placed, but this time in the opposite ventricular system, giving time for the original ventricular system to be completely free of infection. The patient was then discharged after 1 month of prolonged ICU stay, after demonstrating partial improvement in gait and cognitive symptoms with no signs of recurring infections. Here we present images from before we removed the shunt from the left side, and then the second image demonstrates a second VP shunt that was placed on the opposite ventricle, that is in the left ventricular system. So from this case, we know that shunt infections are one of the leading causes of shunt failure in NPH patients. C. acnes, which is a slow-growing skin commensal, is an emerging cause of indolent VP shunt infections due to its ability to form biofilms. It should be considered in differential diagnosis of indolent VP shunt infections, particularly in patients with multiple shunt revisions or other established risk factors. Early clinical suspicion combined with prolonged CSF culture incubation is essential for timely diagnosis. Removal of infected hardware remains critical for cure, and awareness of this entity may improve outcomes in similar neurosurgical cases.